Greetings. So, in this lecture, we will talk about the four seronegative spondyloarthropathies. And the way to remember it is pair. Psoriatic arthritis, A is ankylosing spondylitis, I is inflammatory bowel disease spondylitis, and R is reactive arthritis. Okay? There's a lot of things that are common between these four, so that makes it easy to remember. And there's some differences that I want you to remember as well. So let's see the common stuff. They're all seronegative. There's no blood test. Diagnosis is generally history and associations. Okay, males more than females. Treatment is NSAIDs. So again, we don't prefer NSAIDs and corticosteroids, but here actually the treatment for most of them is NSAIDs. Okay, and they're if they have issues that are related to peripheral joints, we can use DMARDs, and then we can have tumor necrosis factor alpha that we can use as well. Okay, so that's what's common with all of them. Okay, easy? Perfect. Let's move on. What's different? Let's start with reactive arthritis. I know I'm picking on the R first. That's because it is acute monoarticular arthritis. While the rest three, which is psoriatic, ankylosing spondylitis, and IBD are what? They are chronic polyarticular arthritis. So in other words, these three are chronic in nature and they involve more than one joint. Reactive arthritis is acute in nature and involves generally one joint. Is that good? So that's on in history right off the bat, even though we're clubbing it together. That's the big difference when it comes to diagnosing it. What else? Psoriasis plus arthritis gives you psoriatic arthritis. So if a patient in the question has psoriasis, pitting of the nails, psoriatic lesions on the skin, and they have arthritis or swelling of the joints, especially peripheral joints, they're trying to tell you this is psoriatic arthritis. If they've got inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, and now they start to have arthritis, now you have inflammatory bowel disease spondylitis. Okay, that's how they're going to tell you in the question, and actually a lot in real life as well. Last but not the least, ankylosing spondylitis. It's going to be a male with morning back pain and stiffness, which is sacroiliitis. And the biggest thing is it's going to be a younger male. Okay? So which is going to be like, wait, younger males shouldn't have sacroiliitis and back pain and, stiffness in the morning. Okay? But that will be a classic presentation of ankylosing spondylitis. Okay? So let's take a look in detail. Let's start with reactive arthritis. The way to think about reactive arthritis, if you guys have seen Family Guy, there's a character Quagmire in there. But that is how I remember a younger male who is at a high risk for this disease. And essentially, they have three things: can't pee, can't see, cannot climb a tree. They have urethritis, conjunctivitis, and arthritis. Can't pee, can't see, can't climb a tree. If you got these three, the question is trying to see if you know what reactive arthritis is. And you've got acute monoarticular arthritis. This is what you have. Now here, this is caused by non-gonococcal infection. However, the joint does not have infection in it. The joint doesn't have infection. If the joint had infection, this would be septic arthritis. But this is not. This is where the infection may be still in the genitals or another area. Okay? And again, this is an immune process which is causing the arthritis. So it's the infection, I'll clarify, is not in the joint. So you're not going to have an arthrocentesis that is going to give you a septic profile with opaque greater than 50,000 WBC count. Good? Okay. So again, patient comes in, acute monoarticular arthritis, can't see, can't pee, can't climb a tree. Urethritis, conjunctivitis, arthritis. It is caused by an infection elsewhere, and one of the infections is non-gonococcal infection in areas where you can have an STD or a non-gonococcal infection. So it's not in the joint. Okay, so again, you do arthrocentesis, but it's not septic, it's inflammatory. So what do? Check for all the areas where you can have the sexually transmitted disease or non-gonococcal infection. Okay, mouth, genital, and anus are three most common areas. If there is an infection and it's chlamydia, treat for chlamydia. And remember, chlamydia, if you treat for chlamydia, you treat for gonorrhea. Okay? Treat for chlamydia, treat for gonorrhea. That's to treat the underlying cause and diagnose the underlying cause. If there's no chlamydia, don't worry about it. You don't have to treat anything. For the actual arthritis, it's non-steroidal anti-inflammatory drugs such as ibuprofen and time, and it's going to get better. Okay? That's reactive arthritis. And that's acute monoarticular. The other three, psoriatic, ankylosing, and IBD, are chronic polyarticular. And again, if you have psoriasis or psoriatic lesion, pitting of the nails, and now you have arthritis, you got psoriatic arthritis. How do you treat it? NSAIDs. And again, because it doesn't involve back, it may involve peripheral extremities. You may add DMARDs and anti-tumor necrosis factor alpha. Again, treatment psoriasis may not help the arthritis. So those are two separate entities. That's different from IBD spondylisis, where treating the Crohn's disease or the ulcerative colitis or the inflammatory bowel disease actually helps the arthritis. In this case, it does not help the arthritis. Arthritis has to be treated separately, and the psoriasis has to be treated separately. Treating psoriasis does not actually help with treatment of the psoriatic arthritis. Good? Easy. Ankylosing spondylitis, right? Younger male with back pain, stiffness, and sacroiliitis. So they come in, younger male, chief complaint of low back pain, sacroiliitis, worse in the morning, better with activity, worse with rest. And again, it's seronegative. There's no blood test for this. It's a clinical diagnosis. If they're not diagnosed and managed early, later on they may be x-rayed, or their back may be x-rayed, and they may have something called a bamboo spine appearance, which is characteristic or pathognomonic for ankylosing spondylitis. How do you treat it? You manage the inflammation. Remember NSAIDs, that's it. PT and exercise, and anti-TNF alpha for people that don't do well on NSAIDs. And again, sending them over to rheumatology. Okay. Last but not the least, inflammatory bowel disease spondylisis. So patients got either ulcerative colitis or Crohn's disease, and now they start to develop arthritis. Okay, because that's what inflammatory bowel disease is. That now you have IBD spondylisis. So here the treatment is treat the inflammatory bowel disease. The arthritis will get better, which is different from psoriatic arthritis where you have to treat the psoriasis, but that may not help the arthritis, so that has to be treated as well. Okay. Again, we'll talk more about inflammatory bowel disease and its management in the gastrointestinal lecture. Perfect? So, in summary, uh, seronegative spondyloarthropathies. You have the pair, psoriatic arthritis, ankylosing spondylitis, IBD spondylisis, and reactive arthritis. Out of this, psoriatic, ankylosing, and IBD are chronic inflammatory arthritis that are usually polyarticular. Reactive arthritis is the only monoarticular, um, acute monoarticular arthritis. Okay. What's common? They're all negative for blood tests. It's just history, more males than females treated with NSAIDs. And if there's peripheral joint involvement, DMARDs, and tumor necrosis factor alpha. Psoriasis plus arthritis is psoriatic arthritis. So you'd have psoriatic lesions plus nail pitting. Essentially, one treats it with NSAIDs and DMARDs and TNF alpha. Again, treating psoriasis doesn't help. Ankylosing spondylitis, younger male coming with low back pain, stiffness, sacroiliitis, worse in the morning, gets better with activity, worse with rest. And again, we give them NSAIDs and tumor necrosis factor alpha if that helps in exercising and physical therapy. IBDs, ulcerative colitis or Crohn's disease plus arthritis. And again, manage their ulcerative colitis and Crohn's disease, and the arthritis gets better. The one which is the odd one out is quagmire or reactive arthritis. So can't pee, can't see, can't climb a tree. So you have urethritis, conjunctivitis, arthritis. Again, they come in. How do you treat the arthritis? Once diagnosed, so again, when we aspirate the fluid, it's inflammatory, so it's not septic. However, it can be caused by non-gonococcal infection in the genitals or in anus or in mouth or in areas where semen can be, where there has been where there has been contact, where one can get STDs. So it's not in the joint, it's in those areas. So what do? We screen the patient for those areas and see if there's an STD. If there is, and it's non-gonococcal infection like chlamydia, we treat them for chlamydia and gonorrhea. And for the arthritis, we just give them NSAIDs and time. And it's not actually the infection growing in the joint. And that's very important because that separates it from septic arthritis. So that is actually seronegative spondyloarthropathies.